Now we will discuss the diseases of the drainage system. First of all, we will discuss the diseases of the drainage system, and then we will go to the diseases of the secretory system. Okay, so diseases of the drainage system, the first one is the congenital and acquired nasolacrimal duct obstructions. As we discussed previously, this is the nasolacrimal duct. So when there is obstruction, this can be a congenital and this can be acquired nasolacrimal duct obstruction, which is called shortly NLD. Okay. The second one is the acute canaliculitis. The third one is acute dacrocystitis, chronic dacrocystitis, and watering eye. These are the different diseases of the drainage system. First of all, we will discuss the congenital nasolacrimal duct obstruction. So, congenital NLD. What is the pathogenesis? Why the congenital nasolacrimal duct obstruction develops? This is because when a child borns, there is a membrane. Okay, this membrane, in the distal portion of the nasolacrimal duct, this membrane is non-canalized. Okay, and this canalization occurs in few weeks after birth. But if this membrane remains non-canalized, what will happen? It will result into congenital NLD. So when normally when a child borns, this membrane canalized and there is a normal patency. But when this membrane remains non-canalized, then it results into the congenital NLD. And it can also be as a result of if there is male development of the punctum. Okay, if there is male development in these small openings, or there is male development of the canalicular regions. So these all can contribute to the NLD. But the major portion which causes the congenital NLD is the non-canalization of the distal portion of the nasolacrimal duct. So this is the congenital nasolacrimal duct obstruction. What are the signs and symptoms? How the child will present? Because we know that the tear production, as we discussed previously, that the tear production starts at about 3 to 4 weeks after birth. Okay, so the tear production starts and it takes this duration. So that's why the child will also present at this duration. The child will present after 3 to 4 weeks after birth, because this is the duration of tear production. Now, the child will present after 3 to 4 weeks after birth. He will present with, mostly the condition is bilateral, but it can be a unilateral. Okay, so mostly the condition is bilateral, but it can be a unilateral. He will present with watering eyes. There will be lacrimation, epipora like symptoms. So there will be watering eyes, and there will be mucopurulent or mucoid discharge. So the mucoid or mucopurulent discharge will be present, and it will adherent to the eyelashes and to the lid margins in the medial canthal regions. There will be the mucoid or mucopurulent discharge. And if we perform the regurgitation test, if we press on the if we press like this on the nasolacrimal sac, this mucopurulent or mucoid discharge can come out. This is called regurgitation test. By pressing the nasolacrimal duct, so the pus and the mucoid or mucopurulent discharge will come out from the lacrimal puncta. Now, if we should differentiate, we should make a differential diagnosis, because when a child present with watering eyes, there are other differential diagnoses. For example, it can be, for example, I have to erase this. Okay, so we have to make the differential diagnosis, for which I have make a mnemonic called PICK, P-C-C-K, PICK. If a child present with watering eyes, then you should make a differential diagnosis of punctal atresia, in which the punctums, these small openings, doesn't develop properly. Okay, there can be conjunctivitis, and we know that in the children the most common cause of conjunctivitis is chlamydia. Okay, and the third can be congenital glaucoma, and it is important. In the book they are saying that it is important to exclude congenital glaucoma with a child present with you with watering eyes. So it can be a congenital glaucoma, it can be a keratitis in which there is the inflammation of the cornea, it can be uveitis, it can be iridocyclitis. So these all conditions can be the differential diagnosis of the congenital NLD. Now what is the treatment option? The treatment options we have the conservative treatment option and we have the surgical. In the conservative treatment option, spontaneous patency, okay. Remember, in 90% in children, this patency develops, this non-canalized membrane become canalized in about 6 months, okay. In 6 months, their spontaneous patency develops in this congenital NLD, and in 95% children, this patency develops in 9 months. So we should delay the surgical procedure by 6 to 9 months, because in these children there is the non-canalized membrane become canalized in 6 to 9 months. So we should delay the any surgical procedure up by this amount. Now the second one is that we will advise the parents to do a digital massage. We will advise them that they should do a daily digital massage of the lacrimal duct, nasolacrimal duct and sac. So when they are massaging, for example, they should do a massage of 10 strokes 4 times a day. So with this massage, it will generate a hydrostatic pressure, and this hydrostatic pressure may open this obstruction. So digital massage is another option, conservative option, and we will also, because this is the obstruction, so there will be the infection, there is the chance of infections. So we will advise them systemic and topical and systemic antibiotics. Okay. So these are the conservative options. Now, what are the surgical options? What are the surgical options for NLD? Okay, I'm sorry guys. If the duct doesn't open by 6 to 9 or 4 to 6 months, then we will indicate a surgical procedure. And the first surgical procedure is probing. In probing, what are we doing? That we will take a probe and we will insert into the punctum and canalicular region, and then through the sac we will pass to the duct, and we will overcome the obstruction. So this is called probing. Okay. And after probing, if we suspect that whether it is open or not, for confirmation we will do irrigation, probing and irrigation. Okay. So by syringe we will irrigate the nasolacrimal duct, which will confirm that whether the duct has opened or not. Now, other surgical options we have we can open this congenital duct through the celastic tube. Okay, with celastic tube we can open the duct, and another procedure can be balloon catheter dilation. So we will insert the balloon catheter and we will dilate the duct. So it can be another option. So celastic tube, balloon catheter. Okay. So balloon catheter and celastic tube, they can be another surgical procedure. If we do all these procedure and despite of them the nasolacrimal duct doesn't open, what will do? we will do DCR, dicrocystolinostomy. Okay, dicrocystolinostomy. DCR, dicrocystolinostomy. It is the operation in which we make an opening in the lateral wall of the nose, and we directly open this sac into the nose. We create a passageway between the sac and the nose. This is called the DCR. We have two types of DCR. We have external DCR, and we have transnasal or endoscopic. Transnasal or endoscopic DCR. In external approach, we are making an incision through the skin. So through the skin, we will make an incision, and in this way, we will open the lateral wall of the nose, and we will make an opening. We will create a direct passageway between the nasolacrimal sac and the lateral wall of the nose. And in this way, we will bypass this obstruction. This is the external approach. This is the external DCR. And we have the transnasal or endoscopic DCR. We go through the nose. We go through the nose, and through the laser, we make an opening from the nose. This is called external or transnasal DCR. But the success rate is more in external approach. But there is problem with the external approach, that we will have a scar formation in the external approach. And in transnasal approach, this is as compared to the external approach, transnasal is not so successful. It is a successful approach, but it is not like external approach. The success rate is more in external approach. But in transnasal approach, we will not have scar, but in the external approach, we will have a scar. So there is one advantage and one disadvantage in both of them. In one we will get a scar, in another we will get less chance of successfulness. Okay. So this was about the DCR. But remember, in children, we indicate DCR after 4 to 5 years. So we have to wait after 4 to 5 years. We have to wait 4 to 5 years to indicate DCR in children. So if the probing, if the celastic tube, if the balloon catheter dilation, they all are failed, then after that we will have to wait for 4 to 5 years to indicate DCR. Okay. So this is about the congenital nasolacrimal duct obstruction and its treatment, signs and symptoms. Now, acquired NLD. In acquired nasolacrimal duct obstruction, the main problem is the pathogenesis is the involutional stenosis, which is idiopathic. We don't know the cause. But in involutional stenosis, we know that in involutional changes, it is happening in elderly people. There are atropic and involutional changes. So due to the involutional and atropic changes, the ducts becomes obstructed. Okay, this is called involutional stenosis, and it is the most common cause of the acquired NLD. But remember, it can be caused by other local inflammatory condition in the duct. It can be caused by the dacrolith or cast formation. It can be caused by sarcoidosis or TB. Local, for example, if there are nasopharyngeal carcinomas or cancer which infiltrate the duct. So these all can cause the acquired NLD, but the most common cause is the involutional stenosis. In signs and symptoms, it is about similar to congenital NLD. It can be a bilateral. There will be watering eyes, and there will be mucopurulin or purulin discharge. Regurgitation test may be positive, and there will be the recurrent attacks of conjunctivitis and dacrocystitis, as will be discussed in the upcoming lecture. Okay. The first line treatment in acquired NLD is the DCR. So in children, this is the last procedure we have to perform. But in adults, in acquired nasolacrimal duct obstruction, DCR is the first line of treatment. Okay. and it is about above 90% successful rate is present in acquired NLD DCR. It can be external, it can be transnasal. So this is about the congenital and acquired NLD.